Oh, yeah, sorry. And just to remind people that this meeting is recorded, and Bryony's just started that. So just remind us some of the key principles that we're trying to enable through People First is making sure staff are involved in improvement and a respect for them and how they do it, making sure we put the patients at the centre of what we do, and helping teams drive improvement. And the biggest thing we find that helps there is sharing ideas, and there's lots of brilliant ones in the hospital and outside of the hospital, should I add. Next slide, please. So the 5 pillars that we try and work on when we work on this is clarity of purpose and aligning our efforts, helping people plan, do, study, act, and simple changes, using clear data and clear metrics, um, uh, helping teams huddle really successfully. And I think you got some examples of that today. And wherever we can, promote team health. And we've got a particular routine, although I think there's also some routines being slightly modified, but there's a nice routine for helping people view how their team's behaving. Next slide, please. So we've got 5 up here today. So what a great list it is as well. So I think Paul's kicking off, which I think is something to do with theatres, but not Vanessa's. Um, uh, um, uh, Matthew, I think with Mike's help, you're doing something on what you've done on Stannon. So thank you very much for joining. Kerry Colleen's going to talk about her brown belt certification. Vanessa's here to talk about Max Facts. Really great again, Vanessa. Nice to see you again. And there's some SBC congratulations to do for 4 of our staff at the end. So with no further ado, Paul, I think over to you on next slide.
Thank you, Richard. Good afternoon, everyone. My name's Paul and I'm an improvement lead within the Quality Academy. I'm just going to take the next few minutes to take you through my work for my CATA certification within theatres. And next slide, please. So the challenge was to get 0 on-the-day cancellations within ENT, Max Facts, plastics, urology and vascular. And by on-the-day cancellations, I mean the patients that are turning up to the hospital expecting their surgery to be completed, only to be told that once they're in the relevant waiting area, this wouldn't be happening on that day, which is a big inconvenience to the patients and their families. These patients then added back onto the waiting list so they can have the procedure at another time. Next slide, please. So the problem, the top graph shows that during October and the start of November, there were an average of 51 procedures weekly that were cancelled on the day throughout the trust. This number was consistent throughout the year also. The bottom graph shows that the combined on-the-day cancellation cases within those 5 specialities, and this shows that they are responsible for between 30 and 50% of all cancellations within that trust. Urology had the largest number within this group, so I wanted to do a test to see if this would make a difference. Next slide, please. So these are my PDSA cycles, and as part of the CATA method, I started with a low-level data collection to confirm my initial thoughts and lead me in the right direction so I could have the most impact. I did several iterations of this test, which led me to the bigger test in urology with calling the patients the day before their surgery. Next slide, please. For my test, I wanted to bring all urology patients the day before their procedure to see if it would make a difference in the on-the-day cancellation rate, but also to see if it would improve the patient's journey. During the test, I spoke with 171 patients and asked the same 5 questions. Were they aware of the appointment and were they going to attend? 4 of these patients didn't know anything about their appointments, so had to be cancelled. Did they know where they needed to go? Had they been asked to stop any medication or blood thinners? I had to pass these patients back to the service owner of the pre-op if they had any questions around medication, as I didn't want to give out the wrong advice. Were they aware of the starving instructions for the day of surgery? And did they receive a text reminder for their appointment? And only 3 patients out of the 171 confirmed that they'd received this reminder. On the graph, you can see the red lines are number of patients daily on neurology lists, blue for the number of patients cancelled daily, and a black line for a percentage from those patients cancelled. From the 1st to the 18th of January, Freedom and Plym theatres averaged 28% of all urology patients were being cancelled on the day, with patients being unfit or unwell for surgery and patients not turning up as the 2 most common reasons. I started bringing the patients on the 19th of January and finished on the 2nd of Feb. And during that 2-week trial, the on-the-day cancellations came down to only 4%. Next slide, please. I also wanted to have a look into the cost of these delay on the day cancellations, and for the 22 surgeries that were cancelled during the start of January, that's a cost of £20,440 for the time that's not used for those procedures. By doing the test, I wanted to be able to show the service line that what I was proposing for them was a viable and cost-efficient way of reducing on-the-day cancellations, and I believe that my calculations show this. The data for this test has been shared with execs in the service line, and we're looking into ways of incorporating this test into their daily routine to improve the patient's journey, reduce on-the-day cancellations, and reduce the cost of these missed opportunities. Currently, MaxFax are running the same test to see if they can bring their on-the-day cancellations down as well, and they will then introduce this introduce calling patients into their daily routine. Next slide, please. So this is my live Gutter storyboard with all the details on that I have been doing and the results that I found so far. Before I started doing this Kata storyboard, I've always used the project management methods of doing projects, so it took a bit of time for me to get used to the Kata method. But thanks to Ryan and Vicky's patience, we managed to get me breaking into the project down into small areas and focusing on those before moving forward. So a big thank you to Ryan and Vicky for coaching me through this project. Your knowledge within Kata has helped me massively, and thank you all very much for your time.
Well, thank you. Well done, Paul. I'm just going to have first dibs. So really, really well done. I think it's numerically and impact a really impressive project. But I just want to open it up. If there's any, I've missed the chat now, so I apologise. If there's any questions in the chat or questions from around the room. And I think there's a question there from Amanda, which is, do you think there is something more fundamentally wrong with our communication with patients if we're having so many DNAs?
Yeah, I think there could be. That's something that we're looking into at the moment, especially with the pre-op team and the service line as well.
Yeah, and I think that there's two comments I was going to add, and I think it helps with the question you just given back to Amanda. One is really impressive, but I wanted to ask the question, which is, and how did people respond when you spoke to them? Because you've obviously spoken to 171 people, and what was the general response in terms of having been someone ring you and be reminded?
The general response was really positive. Some of the patients have been booked sort of months in advance, so I guess it was just a reassurance to them that the procedure was going to go ahead, unless there was kind of an emergency on the day. But yeah, the feedback was very good from the patients.
Yeah, fine. If the people have got any other further questions, please. Vanessa's got a question. How will this
for us? I've got my hand up as well.
All right, sorry.
That's right.
Please go with your question. Go on.
I think I can just see Vanessa's asking a similar question. Back along when I worked in theatres and MaxFax, we did a similar project with MaxFax, and the booking clock phoned the patient as you have done, and we showed a significant improvement in DNA rate. So the question I've got is, how do we continue this? How do we make sure it happens and sticks?
I'm hoping also with the engagement from the service line, along with the medical secretaries, obviously in the booking staff, that this then becomes part of a job role, and also the more that we keep an eye on it, fingers crossed, it then sticks within every service line.
I'm not sure if there's something, and I haven't got an answer here. I'm not sure if there's something else that we need to do, because I do feel that certainly MaxFax, the booking clerk, is still the same person now as they were then. So I don't know. We need to come up with some magic formula, I think, to make sure that this does stay as business as usual.
So Di, I think it's a really great question. So I'm going to come back to it, Di, by the way. Vanessa.
So my thoughts are on that. It's almost another job for a whole new person interlinking specialities to actually just be the communicator to the patients. Because I know MaxFax, they're really struggling to keep on top of the phone calls. And we had, again, I think 5 cancellations last week.
Yeah. So can I just make sure we go back to, so thank you, Vanessa. I'm just going to make a couple of comments. Thank you. Amanda's taken the words right out of my mouth in the chat. In the history of this, it has also been part of our pre-op standards, and I can go back to the early days of Richard Struthers doing work with pre-op, and it was part of the routines we did right across all specialties in theatres. And I guess there's something around not losing the importance of some of our more personal routines that has a genuine benefit for patients and how they feel when they come in, but also helps us to know whether we need to let this change tomorrow, and the patient has actually stopped their whatever blood thinning drug or whatever drug they need to do. So I think that is being picked up inside of the individual specialties, but I think we might just go back and re-examine, on like your question, Di and Vanessa, about actually making sure it is really, really standard work and valued, but not to take away from the brilliant work done. So really well done, Paul. Well earned, Carter. And I'm not going to ask you any more questions, by the way, so thank you very much. But really, really well done. Right, there's still more questions coming. I'm not going to answer those. And it's really interesting that I think you're getting some input from the text reminder service via the Graham Helmsy and discussions. Although I think people really valued being spoken to. I think that was the key. Right. Thank you. Right, so we're going to move on, and I've forgotten running order now. So Matthew, it's you next.
Good afternoon, everybody. Yeah, so with our project that was brought to us on Stannon, we were looking at length of stay. Obviously, length of stay for our healthcare the elderly patients can be quite lengthy, and we were looking to find a way that we could reduce this and just making 2 days difference to patients is a lot for our patients, and it's a lot in terms of quality of life. About that deconditioning, about all those things that hospitals bring to people in healthcare the elderly in terms of their mental health and all of those things. So we were trying to make a little change that made a big difference. And to do this, we kind of broke it down into several sections where we would look at our MDT. We've got really open MDT, a really welcoming MDT that works well together and have good conversations, but those conversations were becoming a bit lengthy and not as productive as they probably should be. So we had a little look at that. The introduction of the EDD was a big part, and I know going forward that's going to form the basis of how we plan to get people out of hospital. So that forward thinking, that planning for discharge on day of admission is really important, and we can look at lots of things within that in terms of our average stays for patients with specific diseases or conditions that brought them into hospital. And we're also looking at the way our nurses record and document going forward into the electronic era, and hopefully getting electronic notes and kind of just bringing us all up to the standards that we should be with the communication that we have with our patients and each other within the MDT. And then also within that, talking about actually how do we ensure that the jobs that we've spoken about in the morning are being done by the afternoon. Next slide, please. So really it was looking at some pillars really to see what we could do to base it around that timely interventions, timely actions, a clear outlook, a clear action plan for all of us to work to, and then looking at the support in terms of discharge and getting those done as early as possible. So trying to reduce that length of stay really. Within our MDT, kind of having a look at it, how we were doing with it, were we coming up with things that were pertinent, were there better ways to do things really. So having a concise MDT is massively important, that we look at, and this was part that I was really impressed with our team, because actually as we talked about it, we kind of drove change and drove other people to join in. So that was really good having the service improvement team here to kind of drive that forward, because sometimes people they get to a point where they don't want to be done to, and then they actually do, which was really good. So our consultant actually looked at what we were planning on doing and then said to himself, well, actually, I think we could do it better this way. And we talked about patients being medically fit for discharge. So actually at that point, we just need to hear from physios, we just need to hear from OTs, we need to hear from discharge case managers, and taking all that medicalized part of it out, because actually your patient is fit for discharge. So we don't need to talk about anything else now but getting that discharge done. So that really impressed me, actually, that we were able to do that. And those clear actions about what's happened next, where our patients going, what we expect that estimated discharge to be. And that allows us to share that with the patient as well and their families. So actually communicating that to them and letting them know you've come in on day one, you've got a chest infection, and actually we kind of see normally about 7 days, but you've got some complex discharge needs. So actually we might be looking at 10 days. And it's really nice to be able to say that to people and be able to communicate that. And using CPL, having that live at the time, so our junior doctors would be typing into CPL for the management parts, for bloods that need to be taken, for x-rays that need to be done. So you've got a live jobs list going on. We also have our reminder board there that you can see, which has the TTAs on, which were a big bugbear for everybody, I know. And when we were looking at that, there was we'll see in the slide in a minute about actions TTAs, but again, having those jobs on there, and initially it just had TTAs all down that jobs board, and that really got the doctors backed up, because it's not a board to batter doctors with. So we made it that the OT's jobs, the physio's jobs, everybody's jobs were on there, the nurses to maybe talk a patient, the stare assessments, and putting them in the last column. So it's an MDT board, not a TTA board, but it's all designed to try to get our patients out slightly earlier. Next slide, please. So talking of TTAs, when we first started out, we were looking at 30% of our TTAs heading towards discharge, not being actions. Discussions would be had during the MDT. We're nearly there. We're nearly ready to go. Discharge destination, just waiting for bed bureau, but TTA not done. TTA not done. Day of discharge, TTA not done. So it's about actually actioning these things and saying that that person will be going in 24 hours, 48 hours. You can get those drafted and then you can get them released the day before. So yeah, we saw real marked improvement with that, now up to 60%, I think, of all of those being actions. So that's really good, and hopefully driving forward, we'll be able to get more of those done. And it's especially over a weekend, if you're going in, if you're on Friday and you know you've got a Monday discharge, a cover doctor is not going to take the time to do those things. So actually planning on that Friday and saying, by the time you leave this evening, those TTAs need to be ready. It's very important for our especially home first patients, because they're going to need to get home for 11 o'clock or whatever on that Monday morning. So yeah, I'm really pleased with that, and I think the work that service improvement have done helping us drive that data forward and show our doctors, nurses, and everybody that actually there are improvements, and we're not just doing this for just to have something happen. This is actually making things better. So that was really nice to show them this data. And next slide, please. So looking at our combined bed days for 30 patients on Stannon wards, and the data being taken kind of during winter pressures initially, we can see that actually we're seeing a real good downward trend in the length of stay, and all of these actions together, the clear, concise planning, the TTAs, everything combined has helped drive these lines down somewhat. And I think when you see the over 21 days or more patients, they are our complex discharge patients. And the more we can plan towards getting these patients out and making sure that things are done early, the quicker these patients will go. So we'll see a drop in that line as well as we plan better, and as we bed bureau, home first, packages of care start to get, if they trust that we've got our EDDs right, then they can say, actually, we will get you a placement by this date because you will be medically fit. So it's really important to help all of us across the trust to do these things well and actually have a real clear, concise plan for our patients. Next one, please. And so getting those days down, and again, I think this just shows, I don't know if Mike wants to say anything about this, but just the average length of stay today or yesterday, I think you said 19.8 days, which again, we've not seen that bounce back that we expected to see during the winter. So yeah, that's gone well.
Yeah,
Mike?
yeah, exactly as you just said there, Matthew. This is the data looking at the entire year, the whole of last year, and we would expect, as Matthew's already said, winter pressures, the length of stay on the healthcare for the LD wards to be quite high, drop down in the summer, and as he's already mentioned, we would expect a bounce back, and that simply hasn't happened. This is Stannon specific data. So for me, we've kind of pulled back 3, possibly 4 days from that over the entire year. So I think that, along with all of the small changes that Matthew and the team have made, has made, for me, quite a significant difference. Over to you again, Matthew.
Lovely, thank you. So next slide, please. So when we think about change, not everybody likes change. Not everybody likes to be done to. Not everybody thinks that change is going to make any difference. And because we see things go around and come around, people don't appreciate that actually the context has changed, the environment's changed, the technology's changed. Actually, we could try that again. And it's getting people on board to join us in that. And I think as I've said, our MDT is very open, very good. We've got the geriatricians are amazing. They communicate with us brilliantly. We talk to each other. You're allowed to challenge, and that's just so important from an MDT perspective, from a physio, from an OT, from a ward clerk, for all of us. And I will say the ward clerks have played a massive role in this as well. They have updated the systems. They have ensured that the EDDs go in, and they've asked the questions. And initially that's hard because you're asking questions that they don't see the value in, but as we've shown them the data, as we've shown them the difference, it's changed things, and those questions are now being answered without being asked, which is what we wanted to see. So embedding those new processes has happened, and now if I'm not here, or the ward clerk's not here, or the consultant's not here, pretty much 90% of those actions take place. The staff feel more empowered. They've got CPL there that they can look at. They can see what's being done for the patients without going and checking the notes as much, which is brilliant, because actually all those jobs are there. And then our patients go home sooner. And I mean, all of us need that to happen with the car park full of ambulances. We need that flow, and that's going to make a massive difference in the long haul. I think that's me.
Matthew, can I just say really well done, and thank you and the team first of all, and also Mike, who's been helping coach a little bit, so which is great. So well done, Mike. Really appreciate the work, and I must say also your experience and knowledge comes through in this in bags, by the way. So really well done. I hope you feel valued. Because it's an amazing job done. There is, well, I think we'll have one question, which is from Amanda, which she's asked a question, which is, how much difference did EDDs have, and what did you learn about the process around EDDs?
So I will say the first thing that I was asked by Michael was, I think it was an ask from yourself, and it was about having an EDD. And I think initially I just said, well, what I can do is I can put 5 to 7 days on all of our patients. So we did that, and then we looked at it, and actually made it more accurate. And through the process, we've been able to say, actually, we know this person coming with a chest infection, but seeing value in it now, that might be 7 days, that might be 10 days. And every patient is different, aren't they? Everybody's an individual, and their bloods may change and things may change, but actually we can manipulate that, we can change it. It doesn't have to be a fixed point, because actually it may not be, because things will change, but we can estimate, which is exactly what it is. It's an estimated discharge date, and looking to get the patient medically fit, and then moving on to that kind of that more complex discharge pathway, and getting those predicted discharge dates in next will be the key.
Thank you, Matthew. Amanda's question is in 2 parts, but I'm not going to ask you to answer the second part. Maybe you could do in the chat, you could have a little look at the second part of the question and give her a little personal answer about what you'd advise ward managers. But I just want to say, really, really well done. Nice piece of work. And we might come and meet you on the ward and talk about what you're doing now separately, but really, really well done. It's fantastic. Next slide, please, which is, I think, sorry, I didn't do the introduction. I was going to do a big build-up. Someone who's doing loads and loads of improvement work is currently based in Hogwarts Restricted Library, and is going to present to us.
Hi, everybody. So if you don't know me, my name's Kerry Clean. I'm the improvement lead in clinical support services. My presentation today is just going to be about my brown belt certification. So I thought the prudent place to start would be how did I get here? I am one for infographics. I believe a picture tells 1,000 words. So hopefully this can give you a little bit of a background into my journey. So I started within the Trust in May 2020 as an improvement lead within imaging. Prior to that, I was a diabetic podiatrist. So I started on May the 4th, 2020. I'm an absolute obsessive nerd, so that date does stick with me. And I learned CATA within my first week. I participated in the Imaging Improvement Week, which was during COVID. So trying to bring everybody together when you've got to stay 2 meters apart is incredibly challenging, but it was an excellent opportunity to learn. It really showed me everything that was possible with CATA. And my first target condition was to improve the flow to CT during COVID, and able to do that in a safe way. It was certainly trial by fire, because it was very, very difficult to achieve, but we did it. And I think I was got to blue belt very quickly, because we presented that in July 2020. We presented a report out about our change coordination processes, how we were working with task coordination on the wards, and it was a really good understanding of how you can take a really large, complex problem, which people can potentially look at and go, no, I can't do that, that's too big, and break it down into much smaller parts and small, achievable target conditions that eventually kind of rallies everybody towards a unique challenge. So between July 2020 and October 2022, I was working from my blue to my purple belt. And in that, something happened, as you can see from the bottom. I went from the imaging improvement lead to the CSS improvement lead in July 2022. So my responsibility for improvement and the patch, if you like, that I covered grew exponentially, but I saw that as a great opportunity to learn and develop my skills. So I achieved my purple belt through redesign of the CTC pathway. It was not an easy project. I learned a lot doing that, an awful lot. And for me, the really important thing with CATA, and I think it's one of the vital essences of it, is how do you share what you learn? When you learn things, when you maybe did something, you know, that didn't work too well, or you did something that did brilliant, how do you share that with your team to kind of get that contagious improvement culture going? I also was actively teaching and coaching CATA. For any of you that have sat on the CATA coaching within CSS, you'll understand I love to use the analogy of being stuck in the traffic of doing a PDSA cycle, but it sticks and it works, so that's good. And I started working on designing the CATA rollout structure for clinical support services, and I was actively second coaching and actively being second coached by Richard and Ryan, which was immensely helpful, really, really developed me. And then in January 2024, I got to brown belt. It was a long road, but again, it was definitely worth it. And at this point, I am still coordinating the CSS improvement structure. I'm regularly coaching and second coaching, and there's multiple storyboards on the go. So what that really shows, the little person at the top, exactly, shows my journey. You get to the point where you're just starting in the starting blocks, then you can walk, and then you can run, and then you think, there's a lot more that I can do here. But it's about really bringing people along on the journey with you. With Kata, it's not something you're doing on your own. So next slide, please. Brilliant. So this is just a really quick slide on how Kata has developed me as a learner and a coach. I don't feel that you get to any point in your learning journey, regardless of what we do, whether it's learning Kata, learning improvement, learning how to bake a cake, whatever we're doing, and just go, you know what, I'm done now. There's no more I can learn. I can't possibly do that. I don't think that happens. And Kata has shown me that as well. So it allows the breakdown of a complex problem into smaller parts, which is so important. And there's a running joke in my house, which I'm happy to share, which someone says, please don't bring your work home. My husband said to me, please don't bring your work home. But when we were renovating our house and the front room wall went down and all the wallpaper went up, I put a Kata board on the wall and said, this is how we're going to renovate the house. This is what room we're working on now, and this is what we're going to do. So it's relevant everywhere. It challenges you to aim for an aspirational goal, which I think is so important. So you hear some people go, I can't do that. That's too hard. I can't do that. That's got too many people. I can't do that. It's got all these things. It's too expensive. You can do it, but you can do it in smaller ways. It facilitates experimentation and small tests of change, which is, again, a really vital thing to do. And the analogy that I use for this is it teaches you to either bin, bottle, or brew. And mine is, you'll learn if something doesn't work, bin it, but document you did it. So you can, not keep doing the same thing over and again. Bottle it, brilliant, you found the answer, put it on the shelf, make it so anybody can, take it off and use the magic. And brew, it's nearly there. You just need to do a little bit more, because we're so quick to give up sometimes on things. Because that's not working, it doesn't work. It's getting there. Develop on it a little bit more. Show me what you've learned. It constantly challenges you and your learners, but it does it in a healthy way. You can see at the bottom there, that's me coaching Matt, who is my improvement lead in imaging. And we kind of have, again, a bit of a running conversation when we start our Kata coaching of, where's your energy today? Where are we? 1 to 10, and he 9 times out of 10 will go 10 up to 11. It's good. Really challenge me, because that's where I'm going to learn. I'm like, okay, fine, we can do that. It allows you to align a metric to your challenge. I say it's really difficult to start an improvement if you don't know where you are and where you want to go and where you are now. So you want that metric as data over time. And I use the 5 seconds, 5 paces rule with Kata. So within 5 seconds, from 5 paces from your board, can I tell what you're measuring? Can I tell what you're looking at? It constantly develops you as both a coach or a learner. I learned so much between purple and brown belt that it completely changed the way I did so many things for the better. And that's why I say I don't think we give up at one point when we've got to a place and go, yeah, no, there's no further to go. And I want to share that with the people that I coach. It practices continuous improvement mindset, and it allows a contagious culture of succession planning. So the improvement leads in imaging, and we've got Charlotte on the call from pathology. My aim is to get them to purple belt. Matt's already there. Charlotte is getting very close, but you're there, guys. You go and coach the people in your service lines. I'll second coach you. I've got a new starter who wants to coach. You go and do that. By giving that kind of permission, if you like, for people to go and coach others and learn themselves, you're only going to grow your improvement team exponentially. And it encourages and permits a healthy challenge of a project status to develop learners. So there's so many times where people can say, I want to go for a 50% improvement. And I go, oh, do you reckon you could get 60? It's only 10% more. And then they'll get the 60. Oh, do you think you could do 70? Okay, fine. And then they go, next week, I know what you're going to ask me, 80. Fine, it's already up there, it's done. But you've built it in, they know, and it's done in a really healthy way that challenges to achieve the best that they can and we can. So could I have the next slide, please? So one thing I did between purple and brown belt, which for me was quite scary to do, I'm happy to say that it was. I am somebody who doesn't generally like to look too introspectively, or I say I wasn't somebody that didn't like to look too introspectively and think, oh, you know, oh, how am I actually doing? But what I did was I went to everybody that I had been involved on an improvement project with in the last kind of 3 to 4 months, and I asked for 360 feedback. And I said, how am I as a coach for you? How is it going? Do you feel that you're getting what you need from me? And I asked a set of questions, and there are those questions, a couple of them up on screen now. So asking, do I demonstrate leadership on a daily basis? Do I take accountability for coaching and leading improvements? Do you feel empowered to make improvement into your service line? And do you feel supported for your improvement journey? So these are all things that I want everybody to be able to feel, yes, you have. But the real fact of empowering somebody for improvement is they feel safe enough to go, actually, you know what? No, you don't. And it would be really good if we could have this, because I need that to develop. So that's what this is aiming, because it's just like that infographic says on the screen. We rise by lifting others. You know, we don't want to get to the top and be there by ourselves. We want to have brought all our team along with us. So we have a culture and a organization of improvers, if you like. So the next slide, please, which is my final slide. So if anybody has come into contact with me or is yet to come into contact with me, I love a spreadsheet. I can put anything in a spreadsheet. But this is how I monitor Kata within CSS, because I talk about, you know, my learners and coaches having metrics. I have my own Kata board of how I'm rolling out Kata. Yeah, I want to make sure that it's sticking and that it's working. So within CSS, I have a year 1, a year 2, and a year 3 training target. They're quite ambitious, which is what it should be with Kata. But to have 10% of the workforce trained in year 1, 30% in year 2, and 50% in year 5. We track how we're doing, how well are we doing per service line, and what are our belt status. So how many do we have? Are they in the right places? And also, are people keeping up with it? You know, we only need to get, you know, park our car at the airport, go away for 2 weeks, come back. And me personally, I've forgotten how to drive a car. You know, I forget which way to do so, but it's so easy to do with Kata as well. So if you haven't done it, you can so easily lose your skills. So are people in clinical support services keeping up with it? Have they got, and when I say keeping up with it, have they got the right opportunities to coach each other? Are we building a structure where they can talk to each other, where they can say, hey guys, I would really like some second coaching. Is there anybody who'd like to second coach me this week, please? Keeping a track of all of them, and equally looking at what their Kata storyboards are in, because if we've got people who are similar subject matter experts, if you like, it's brilliant to get them to train and coach each other. But one thing I really learned as well, it was something that Ryan did with me that I learned the most from, which was coaching outside of my area. So making sure that I am getting to know the Kata method really well, not the subject matter. Yes, Richard.
Just conscious of time, if you don't mind, Kerry.
Yeah, no worries. So that just brings me, that's the end actually as well. So that brings me to the end. So that is just a little bit about my brown belt journey.
And can I just say, really well deserved, by the way. And it was a fantastic, not just story of your journey, but also a good spotlight on Kata. So thank you for doing all that detail. It's really, really helpful.
No worries.
I'd say while that's been going on, there's been a bit of speed dating going on to get other people on Kata courses in the chat, which I can see has happened. But I'm just going to put another plea in for Kata. There's some really fundamental psychological stuff going on in Kata, which is really important for the organization, both in the coaching culture it supports, but also in the development of people and the alignment to organizational goals, which is really, really important. So really, really well done, really well deserved. And no doubt you'll be chasing Ryan and myself to get a black belt soon, no doubt. So I know how ambitious you are. But really, really well done. And we're going to move on to the next presentation, which I think is Vanessa.
Hi, good afternoon, everyone. So I'm Vanessa, Senior Team Leader for MaxFax Plastics, Upper GI and Transplant. Next slide, please. So the improvement team came to us probably about 6 months ago now to start within plastics. We had a really good team ethos we were working with already before they joined. Next slide, please. So the first thing that we started to look at with the improvement team and within the wider team was what was stopping us. So we identified people, equipment, process, communication, and environmental factors were all things that were issues getting in our way, stopping us from being as efficient as we possibly could be. So I'll now go through each of these factors with you. Next slide, please. So people, first of all, we looked at skill mix of our staff. So working within MaxFax, unfortunately, is a really difficult theatre to be in CT3 because we don't only just cover MaxFax, we cover upper GI and transplant, as I've already said, and they're all three very, very different specialities, as well as plastics. So what we first of all have started doing is rotating the teams around all three theatres so that we can ensure that everybody has understanding and is competent in each speciality. Also, for more additional learning, we're running a focus topic each CME. For example, 1 month we're doing specimens, so the team will go away with their theatres, produce some information, ask questions, anything they'd want to learn. I always say to every member of the team, nothing's a stupid question, ask away, it's a safe place. And then they've been presenting back things that they've learnt. Next slide, please. So next, equipment is a really big issue in CT3 because there's very much minimal storage for our equipment. So we recognise that we require shared airway equipment. This is now readily available. We've got our own trolley to access this. Other kit issues that we struggle with is for our renal kidney transplants and general surgery, because this is based on level 4. We now have a good system in place and have liaised well with band 6s to band 6 on level 4 so that they ask for their equipment the day before, are able to bring it up. Equipment that we aren't able to access the day before because it might still be being used, we now have a board within theatre which this is written on, so that the team in the morning coming in know what they need to get to start the day. My band 6 George has also been busy. She's got a cupboard now which locks, so we can put all of our patient supports for position our patients in that cupboard, because we were finding over the weekend especially they'd just disappear and go walking and you just couldn't find them. So we were wasting a lot of time and travel looking for them. We've also been updating our surgeons' cardexes because we realised they were really, really out of date, and we have actually asked the surgeons to get on board with us as well, so, and send us all the special equipment that they require. Next slide, please. So what are we doing to improve our processes? So currently we've been looking at our consultants' average times for procedures, meaning that when we're doing scheduling and our list reviews, we're getting a true reflection upon the time that procedures are taking. So the scheduling now, we have a really good standard format that we follow so that we know that we're all doing the same things. So we look at the week before with our scheduling to see if there have been any issues then we can raise to look forward to improve upon and mitigate them the following week. And also we have a partner where we have actions so that we can action who's adding a patient or taking a patient off the list. So we know that things that have been asked for in our list reviews are actually being done rather than just sitting on the shelf. Planned overruns are also a bit of a concern in CT3, so that's something we're working on together as a team because it's affecting morale greatly. So we are hoping to have planned 3 session days rather So staff are actually scheduled to work rather than having it ad hoc, trying to arrange a overrun within very, very short notice periods. It was also recognised that there was space left on our operating list for emergencies to be added. After discussion, it was agreed that we'd utilise the list fully and plan to have an allocated list for emergencies. We've also got an allocated stores person now to help with our orders. Next slide, please. So communication as well, CC3 being the area is split on with split levels as a pod. We're encouraging team members to be positive at the start of the day and stop the grumbling, which is culturally has been culturally an issue throughout theatres over time, to stop them grumbling and saying, oh, we're going to overrun. Instead of doing that, be proactive about it, get sending early, get sending on time, be positive about your day. And actually reminding staff that a team of 3 actually is safe operating practice as well, because ideally a 4th member would be great, but if we can't have a 4th member, 3 people are more than adequate to work. Due to being positive at the start of the day, actually it's noticeable that positivity has improved and the atmosphere is really a lot better in theatre. I think it also key, I always make sure I visit the theatre at least 2 times a day, first thing in the morning, later on during the afternoon, to make sure I'm there to troubleshoot if the team have got any issues, and also to engage with the team and help them with morale. There's also been concerned about surgeons not being ready in between cases. This, however, has been identified and has been discussed, and there's been improvement within this now as well. Postbridge is where our team collect our patients from. We're working with Postbridge and recovery to have better forms of communication so that we don't get backlog of patients within recovery, which then obviously holds up theatre because we can't send for patients, etc. Next slide, please. So theatre environment. So we were looking at our efficiency and turnaround time of our patients, and it was noticed. So one issue we have is there was nowhere to sit our patients when we collected them. So when we collected them, they either had to sit in recovery with patients post-operatively, or we'd put them straight in the anaesthetic room, which a lot of anaesthetists weren't happy with. There was an area outside of theatres, as this picture shows you, was stored with equipment. So we worked hard and emptied the area and made it patient friendly. So now there's a trolley in there that's made up all the time. So we bring our patients up, which means that as soon as we're ready for the patient in theatre, the patient is right next to us, and also improves the patient journey. Next slide, please. So every Wednesday we do a team huddle board. We did start this initially every day, but actually as the team have got more engaged with the huddle board, every Wednesday seems to be a much more sensible approach. So we discuss on there our focus of what we're going to be improving on. This might be, so example, start times, finish times, as I've already mentioned, turnaround time in theatres. As part of this, we also discuss our team health. I have in the past changed the team health slightly, but I've revisited it after having a bit more understanding myself on the leadership course. So we've revisited the health, and we're working with the principle that we've been shown with the Leadership Academy, and that seems to be going well over the last week. And this is also our opportunity to share what's been successful, to give our team morale and actually say, yes, you've done well at this, you've got this, and actually engaging with the team. And the team health is also helping us understand each other's feelings more and being able to coach and help those that need that additional support. Next slide, please. So this is the model we are trying to achieve to get the best turnaround time possible. So to make sure we've got a patient in every area of the process in theatre. my aim as a team leader is to get that time down to 0. Next slide, please. So as I've already mentioned this briefly about start time. So we aim to send between 8:15 and 8:30, but there are often delays which we've been looking at to mitigate. So certain delays could be CT3, they're further away, so it might be a delay because the team have been here in a team brief, they're not ready in theatre. So rather than the whole team being up here for a morning brief, it's just one member of staff that stays, which we rotate, and then any information is cascaded through, and I'll follow that up when I visit them. So that's something that we've looked at. Next slide, please. So this is just some data we've captured. So the average patient call time was 8:39, and average patient entering anaesthetic room time was 8:59. So overall, actually, we're going where we want to go. The start time, the send times, we could do with getting a bit earlier. I think still the start times need working on, which is a real drive. Unfortunately, we have issues with complex patients on Postbridge that need to be seen on day of surgery with complex airways, and also complex surgery. So the surgeons take longer to see them on Postbridge, and then they've got the footfall within the hospital to get from Postbridge up to level 6 theatres for their briefing. So with some hard work, we can, I'm sure, improve on this more. Next slide, please. And this slide is showing the average time in between case for CT3. We can see with the blue line that the trend, there was a significant drop between the weeks of the 25th of December down to the 8th, 12th of January. We're continuing to average around those times, so that's really helpful. Richard?
Yeah, I'm just going to push you along for time, Vanessa. Is that right, please?
Yep. So next step is to maintain. Oh, next slide, please. So the next step is to continue as we're doing, maintain our group huddles. I've got the team involved now in the group huddle board, rather than myself leading it. Next slide, please. And just a final one, team morale, we try to encourage our teams to go out and actually have a bit of time away from the operating theatre. Thank you.
Can I just say, really well done, Vanessa. You told a really nice, complete story, and I thought it was really important. And I just want to also say a thank you to all the presenters today, because for everybody, this normally not what we do is get online and talk to a whole bunch of 20 to 40 people at times, but you've all done it excellently, so thank you very much. Vanessa, I'm not sure if there's any questions going to pop up, but I really do like your reflections on the fact that you adapted Team Health, you've had some training and used it again. How's that going, just the Team Health doing it slightly differently again this week, is how you're using it?
Yeah, so actually it's going well, and I've explained to the team a bit more because we had CME on Wednesday last week, and after doing the course, I've brought it back again and spoken to them and explained to them more about it because I've got that better understanding, and they seem to be grabbing the concept.
Fantastic.
So I'm going to keep pushing it.
And I've put something in the chat which you can read later, which is very complimentary of you.
Okay.
I think it's been a real joy to work with you, by the way. So the professionalism, your knowledge, and how personal we are with your staff is just a joy to work with. So I think you've done a really, really great job. So I just want to say really, really well done. It's fab. I think so. I'm going to, if anyone else has got a question, please add it. But I'm just going to move on to the next slide. We've got a few left. I'm going to do this really, really quickly because we've only got about three minutes of time. We're not going to do a big announcement for everybody, but I just want to not underestimate the achievement of the 4 people on the slide. So Dan Stevens from pharmacy, Kate Dunn from our team, Craig from Therapies, and of course Carrie again, have now qualified as specialist practice coaches. That isn't a short thing, by the way. It's over a year's worth of work, study, and practice. The photograph that's taken, they're actually stood outside the Toyota plant in Derby after a day's visit, really getting from the most experts of lean and visual work, some of the, and a deeper understanding, but they've all delivered an improvement week or a rapid improvement event, and all delivered results, and I've been through the mill with the chief medical officer and a chief nurse in terms of an assessment day. And I want to say super congratulations. This is a really great level to get at, and that now brings us up to 8 people in the organisation who are working at that level. So I just want to say a super congratulations to all 4 of them. It is really well achieved, and I'm sure, by the way, there's a slight bias here to CSS with 3 of those candidates. Wow. And I know surgery have got one lined up and medicine have got one lined up for the next cohort of training, but super well done to all of them. It's a really great achievement. So some of them may be on the call. Carrie still is here, so she'll take another bow, but well done to all of them. It's really appreciated, and good luck. We hope to have a slightly fuller report. It is slightly earlier in the month because there's some leave to tidy up in March. We've got lots of work going on at R&D. Pharmacy should have been on today, but the person wasn't able to speak, as was Cath Lab, and again, someone wasn't there to speak. But hoping some of the early floor on ward stuff, some of the surgery people first practice, and respiratory ward stuff will be here. So thank you for all the prep work in the background, everybody. And I think I look forward to hearing from you and seeing you in about 3 or 4 weeks' time. All right. Thank you very much, everybody. I hope you enjoyed the report out.
Thank you, Richard.
all.
Thank you all.